Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Thanks for tuning in to episode 6 of the Super High Yield Anesthesia Podcast, and today we will talk about thoracolumbar neurosurgical procedures and anesthesia. So, like the previous episodes, we're going to use Jaffe's Anesthesiologist Manual of Surgical Procedures as our primary source for this episode. And we're going to break it into surgical considerations, and then we'll move into the anesthesia considerations from the preoperative, intraoperative, and the postoperative periods. And before you start listening, I would highly appreciate it if you take a look at the pre-survey that's in the description of this episode. And it's only one question, so once you get that done, then you can move on to the rest of the episode. All right, all of that said, let's go ahead and get started. So first of all, this episode pertains to the following types of procedures. They include the anterior or posterior thoracic spine surgery, anterior lumbar or lumbosacral spine surgery, the posterior lumbar spine surgery, posterior lumbar fusion and instrumentation, and lastly, combined anterior-posterior instrumentation of the thoracic and lumbar spine. So quickly going through the surgical considerations, generally the incision is going to be in the posterior thoracic or lumbar area wherever they're doing their work, though the surgeon could elect to do abdominal or flank approach. So usually if we a two surgery team, you have like the general surgeons kind of get access and then the neurosurgeons come in to do the anterior approach. So regarding posterior lumbar surgical considerations, position is generally prone. The incision is usually posterior midline. Any special instrumentations generally is just things like the operative microscope. The antibiotics beforehand are generally just cefazolin. The surgical time is generally 1 to 2 hours per single level, and add on half an hour to 1 hour per additional level. The EBL for these cases is generally very low, so between 25 to 500 cc's. The post-op disposition is generally go to PACU, then to the floor. The mortality rate for lumbar surgeries, thoracolumbar surgeries is 0.5%, and the pain scores afterwards is usually 4 to 7. Okay, that surgical stuff aside, let's move on to the more fun part, the anesthesia considerations. First off, the preoperative phase. And generally, these surgeries are done for things like herniation of the lumbar or thoracic intervertebral disc, spinal stenosis, spinal listhesis, traumatic injury, or removal of spinal tumors. And like in the previous episodes, we're going to go through systems-based preoperative considerations. So first, neurological. So you have to take an account for any motor weakness or any muscle atrophy or any like sensory deficits prior to surgery, and also take note of bowel or bladder dysfunction for patients with chronic herniated disc. So the general test for this is the MRI, and usually it's done to diagnose whatever illness the patient presented with. Next system is hematologic. Although it's rare, it's possible to have significant blood loss in both the anterior and posterior approach, or if something happens during instrumentation. So it's a good idea to always have 2 units of blood available for the patient, and definitely consider a red cell salvage device. So things like Cell Saver is a good idea to have in the room if available. And thing to keep in mind is the possibility of blood loss increases with the increased number of levels that the surgery team is going to work on. Laboratory-wise, at least get a pre-op H&H or a CBC, as well as a set of coags. Regarding pre-medication, it could vary depending on your institution. but you could give anxiolysis, so things like midazolam, and preoperative pain medications, so like things like meperidine, 25 milligrams. So again, definitely talk to your surgery team and make sure that you're on the same page. Okay, next section is intraoperative. For these cases, definitely general anesthesia with ET tube. Though it's possible to do spinal and epidural for lumbar surgery, though it is not done routinely because of concern for interfering with neurological function and deficits, and sometimes neuroaxial techniques will fail on you, and that's not what we want. So regarding induction, basically you just do a standard induction unless they're doing neuromonitoring. And if they are doing neuromonitoring, a combination of propofol and succinylcholine, or even a low-dose rocuronium at 0.5 mg per kg would be great. Another thing you can do is a remifentanil bolus at 1.5 mics per kilo. If the surgical position is prone, consider getting a reinforced tube. And if they're going for a transthoracic approach, they may require one lung ventilation, and this will require a double lumen tube to deflate one of the lungs. Okay, regarding maintenance, basically standard if there's no neuromonitoring. Otherwise, you use TIVA. For posterior approach, once exposure is completed, there's no real need for muscle relaxation. So that's something to keep in mind. If they're doing a thoracoscopic or anterior abdominal approach, the muscle relaxation is going to be necessary until they're basically done and closing. And obviously, for neuromonitoring, we'll kind of save that for a different episode. And again, that's episode 3, if you like a more in-depth discussion on neuromonitoring. Next, regarding emergence, basically standard emergence after a patient returns to the supine position. If there's any concern for difficult intubation or a concern for airway edema, consider leaving the patient intubated overnight, or even consider doing a leak test before trying to extubate. And again, remifentanil, though it's great for pain control throughout the procedure, will come off very quickly once you turn off the drip. So you'll need to bridge it with a long-acting opioid. Things like Dilaudid would work great here. Okay, regarding blood and fluids, it's recommended to get 2 peripheral IVs between an 18 to 16 gauge. You can use all sorts of fluids if you like, NS versus LR. Try not to exceed a max of 40 cc's per kilo, as this increases the risk for ischemic optic neuropathy. And if the patient requires more fluids than 40 cc's per kilo, try to use things like albumin 5% or even blood. For monitors, you'll use your standard monitoring, and for most cases, you'll likely use an arterial line for tight blood pressure control, but I guess this will depend on the case and your attending. But otherwise, a CVP could be an option. A urinary catheter is definitely a good option, especially if it's a long procedure and you want to monitor urinary output. And if you want to, you can use a set line or a BIS monitor. But if the patient is going to be neuromonitored, you can just ask the neuromonitoring tech for depth of anesthesia. All right, regarding positioning, definitely pad the pressure points, check the eyes and ears, and maintain a neutral C-spine position. Yeah, so depending on the approach, if they do an anterior approach, the patient would be supine. If they're going for a retroperitoneal or transthoracic, obviously they're going to be lateral or semilateral with some flexion. And if they're doing a posterior approach, you're going to flip them like a pancake into a prone position. And for that, you basically just try to maintain neutral position with a foam pillow with the cutout for the eyes. Maintain head at the level of the heart, and definitely be careful when you're flipping. And generally for lumbar procedures, the patient would be in a Superman position, so you have access to the hands. So that would be great for your lines. Okay, last, postoperative things to keep in mind. The most common complications are things like hypotension, hemorrhage, nerve injury, and blindness. For regarding pain management, you can do a variety of things like IV acetaminophen if you haven't given it intraoperatively, Toradol, a PCA pump, or even an epidural opiate. Tests, if you're concerned for hemorrhage or hypertension, includes things like getting a hematocrit. All right, guys, that kind of sums up this episode on thoracolumbar neuro anesthesia. So now is a good time to pause this audio recording so you can do the post survey. And the reason why I have this is to kind of assess whether or not you're gaining anything out of these episodes. And the question on feedback obviously allows you to tell me what works well for the episodes and what doesn't, and how I can improve for future episodes. And to close this discussion, I'm going to give you another fun fact. And this one is that tigers have striped skin, not just striped fur. Cool, man. All right. And if you like to stay updated with any new episodes, or you like to connect with me, I have a bunch of social media platforms, things like Facebook, Twitter, Instagram. I have my own website. So if you like to connect with me, definitely follow those links in the description. All right. Thanks for your time. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.